So let's talk a little bit about control of reproduction. This is basically a neuroendocrine phenomenon, as I said earlier. Endocrinologically, it is really mediated in both the male and the female through what's known as the hypothalamic pituitary gonadal axis. And this axis consists of, naturally enough, the hypothalamus. The organs involved are the hypothalamus, the pituitary, and the gonads, okay? The hormones involved are GnRH and FSH and LH, and your steroidal hormones, testosterone in the male primarily and estradiol in the female primarily, produced by the gonads. So what happens is the hypothalamus secretes GnRH. The GnRH is carried to the pituitary, where it acts to stimulate the release of FSH and LH in both the male and the female. FSH and LH stimulate the gonads to release testosterone in the male and estradiol in the female. Okay, and that's the way this axis works. Now, and here we go, you have gonadotropin releasing hormone, henceforth known as GnRH. You have follicle stimulating hormone and luteinizing hormone, FSH and LH, those are your gonadotropins, okay? This is effectively a feedback phenomenon. So what you have here is you have feedback of testosterone in the male and estradiol in the female back upon the pituitary and the hypothalamus. So the more, in the male, the more testosterone you secrete, the more it feeds back on the pituitary and limits the secretion of FSH and LH. This is negative feedback, and it controls the secretion of testosterone. The same thing happens with estradiol in the female. It feeds back upon the pituitary and limits the secretion of FSH and LH, and so the secretion of estradiol is kept under control. That same feedback inhibition takes place upon the hypothalamus, something that's particularly important when we talk about puberty in a second. The more testosterone in the male and estradiol in the female you have, the more negative feedback you have upon the hypothalamus and the less GnRH you secrete, and that keeps the secretion of these two hormones in check, okay, under control. Inhibin feeds back upon the pituitary as well. It's a negative feedback. It is secreted by the gonads, and the more you have, the less FSH and LH is secreted. Activin feeds back positively upon the pituitary. The more activin you have, the more FSH and LH you have. Okay, so that is an example of positive feedback. These do not feed back upon the hypothalamus like estradiol and testosterone do. Okay, so this is our HBPG axis. Notice I talked about estradiol as forming a negative feedback loop. That is normally how it works. However, there is a portion of the ovarian cycle, the menstrual cycle, where estradiol has a positive feedback effect, and we'll talk about that in some detail when we get to the menstrual cycle and the female reproductive lesson, okay? The portal circulation, this communication between the hypothalamus and the anterior pituitary, which is where your FSH and LH are secreted, is through a portal system. So the GnRH is secreted into the bloodstream here and into where the capillaries are. And then you have this transport through a portal vein to another capillary bed. That's the definition of a portal system. You have a vein mediating blood transport between two capillary beds. And in this case, your second bed is in the anterior pituitary. And the GnRH stimulates the release of FSH and LH from the anterior pituitary, along with a variety of other hormones. TSH you will learn about in more detail when you talk about thyroid hormone. GH is growth hormone. That'll come up in the life cycle block. PRL stimulates the release of prolactin, and that is involved in lactation. We'll talk about more about that in the pregnancy lesson. ACTH you may already be familiar with. This has to do with stimulation of secretion from the adrenals. And you'll talk about that in more detail in the life cycle as well. Okay, so this is the anatomy of the system. Again, GnRH into the bed secretes, causes secretion of LH and FSH from the anterior pituitary. The chronology of sexual development is sort of an overview. As an embryo, you have sexual differentiation taking place. This is primarily takes the form of development of the Wolffian or Mullerian duct system. In the male, the Wolffian duct system is the precursor to the male urogenital structures. So that includes the epididymis, the vas deferens, the seminal vesicles, etc. Okay. In the female, you have the Mullerian duct system that develops into the uterine tubes, the uterus, the cervix, okay, and the upper third of the vagina. So these are the two structures in the embryo that eventually develop into the fully mature male and female reproductive tracts. Okay. As a child, there's a period of sexual quiescence where not a whole lot's going on, and then you hit puberty, and your primary sex organs and your secondary sex organs and secondary sex characteristics mature and develop. So, this is, of course, where the menstrual cycle begins to take place in the female, so this is the continuation of that sexual development. And of course, once you start the cycle, you have achieved sexual maturity, and these are your primary reproductive years, okay? And this is considered to be a period which is characterized as being climacteric. What that means is it ascends to a peak and then declines. So your reproductive capability peaks at about 30 years old and then gradually declines afterwards until you have a cessation of reproduction. In female, this is known as menopause, okay? And we'll talk briefly about that in a second. Let's talk a bit about puberty, okay? Again, this is convenient time to talk about this because mechanistically it re-emphasizes the function of negative feedback in the hypothalamus pituitary gonadal axis. Okay, so this is where all your physiological, morphological, and behavioral changes take place as you transition into the adult state. Okay. Growth obviously begins, as you're an embryo, and once you're born, this is the rate of growth on this graph. It's on the y-axis as a function of age in years on average for the typical male and female, male in red, female in blue. And you can see you have a fairly large rate of growth as a child, but it gradually declines as you get older and older, but you're still growing at a given rate. And then both the male and the female hit what's called a growth spurt, where that rate of growth shoots up, and that growth spurt is associated with puberty. And that peaks and then declines as you enter adulthood, okay? And you'll notice that this this growth spurt takes place earlier in the female than in the male. Females attain sexual maturity earlier than males, okay? And this is thought to account for the fact that males typically grow to a larger size. Because this growth spurt hits later in males, they spend more time during childhood growing before that growth rate starts to decline. In other words, you have 2 extra years of childhood on average, about 2 extra years, to continue to grow where the growth plates are open in the bones, and where the long bones continue to grow, and that plate closure doesn't take place. Of course, once those plates close, you can't grow anymore, and we'll talk about that more in the life cycle block. So this is thought to account for the fact that males typically grow to a larger size because they have an extra couple of years of growth here in childhood before this growth spurt hits, and then the epiphyses close, those plates close, okay? All right. So this is sort of a graph of sort of what happens in a typical male as maturity takes place. As you get older, you'll notice that your LH and FSH gradually increase on average in both the male and the female. Okay, you'll see this. And that increase looks pretty linear, but it sort of disguises the fact that there are peaks and troughs taking place as you approach puberty. And as you go through puberty, in both the male and the female. So let's take a look at that. Pre-puberty, if you look at plasma LH, one of your gonadotropins, it's at a relatively low level during childhood, pre-puberty, and it's relatively steady, okay? But then, during puberty, you hit this phase where you get peaks at night, and then during the day it declines back to a smaller level. So on average, you've got an increase in this, and it looks like a steady increase during puberty, but in fact, you've got these peaks at night that may play a role in terms of causing further development during puberty of the gonads, okay? And then you hit adulthood, and again, you've got spikes, especially at night, but it's more steady than it is in puberty, where you have this big increase at night. And you'll notice that the average level is higher than childhood. And again, these are your reproductive years, okay? So you've got this gradual increase in the gonadotropins, but don't be fooled. It disguises this period where you have these big peaks and troughs at night compared to the day, where your gonads, your body, is being exposed to reasonably high levels of gonadotropin at night. Okay? So, and again, low concentration, then a high concentration at night, diurnal, and then meaning it varies at night versus during the day. And then you have pulses at night, but a relatively steady, high concentration in adulthood. Okay? LH is stimulated by GnRH, and so this pattern ultimately depends upon the pattern of release of GnRH from the hypothalamus. So you can figure that you have GnRH concentrations and release from hypothalamus that more or less parallel this release of LH and FSH. Okay? Okay, so you'll notice that despite the fact that the LH and the FSH are rising relatively steadily, again we have these rises and falls over the course of the day, and that may partially account for the fact that in males your testosterone secretion suddenly takes off once you hit puberty. And this is partly because the testicular size is continuing to increase. So for the same amount of FSH and LH, you will secrete more testosterone. But there's probably more to it than that, and we'll talk about that in a moment when we talk about the sensitivity of the hypothalamus to feedback inhibition in a second. But recognize that the secretion of testosterone takes off during puberty, and this helps mediate a lot of the secondary sex characteristics that you typically see: enlargement of the genitalia, enlargement of the larynx, deepening of the voice, the development of facial hair, broadening of the shoulders, increased muscle mass, and pubic hair, and of course you see your growth spurt here, okay? In the female, it's a little bit the same. You see the steady increase in the gonadotropins, okay? And once again, you have these diurnal changes in the gonadotropins, which may help explain partly why estradiol suddenly takes off and starts to increase to a greater level once you hit puberty in the female. Again, that mediates a lot of the development of a lot of secondary sex characteristics, breast development, pubic hair and axillary hair. You have enlargement of the labia. You have broadening of the hips, and again, the growth spurt here. And then you'll notice that once you get enough estrogen secreted by the ovaries, you start to cycle, and you start to get the menstrual cycle that we'll talk about in such enormous detail in the female reproduction lesson, okay? When you look at the plasma gonadotropins, this is sort of what it looks like. You have this large amount of gonadotropin as fetus, and maybe a little bit in infancy that's probably associated with growth. You have this quiescence during childhood, but notice this increase as you approach, as you enter puberty in the female, and then you start to get these monthly surges in the gonadotropins, which are associated with the ovarian cycle, the menstrual cycle. Those take place throughout your reproductive years, and then you'll notice you hit menopause somewhere around the age of 50, and look what happens to the FSH and LH. All of a sudden, they're really high. And the reason is because during all this period, estradiol is feeding back upon the hypothalamus and the pituitary, and it's limiting the amount of FSH and LH that you secrete, depending upon where you are in the cycle. But all of a sudden, when you hit menopause, as we'll talk about in a second, the estrogen disappears from the system, and now you don't have this feedback inhibition, so you get this large increase in FSH and LH. That can be handy when it comes to detecting whether a woman is in menopause or not. You can look at these, they're detectable in the plasma, and you can see, okay, it's abnormally high and steady. That probably means we're not cycling anymore, and there's not that much estrogen, okay? In the male, if we look at testosterone, fairly high early in infancy or in the fetus, and then you have a kind of this high level right after birth, again probably associated with growth, and development of the sexual organs, probably in both sexes. And again, you'll talk about that more in life cycle, but you see this period of quiescence where the testosterone is really low in childhood, and then at puberty you get this surge in testosterone, and it's relatively high in the adult during the reproductive years, and then it declines afterwards as you reach the climax of those years, and then your decline in your reproductive powers. Probably peaks at about 30, okay? About the age of 30. So let's talk a little bit about what's going on here in terms of what's determining all of a sudden you get this big rise in the gonadotropins and in the sex hormones when you hit puberty. So what we have here is a graph, and on the y-axis you have the rate of gonadotropin release, and on the x-axis we have the concentration of sex steroids, testosterone in the male, estradiol in the female. And you'll notice that it doesn't take very much of these sex hormones to stop the release of gonadotropin when you're a child. In other words, you don't need a lot of testosterone if you're a male to feed back upon the hypothalamus and limit the release of gonadotropin. And what that means is that your steady state level of sex hormone is going to be relatively low, okay? Because the sex steroid is effective at feeding back upon the hypothalamus and upon the pituitary, you don't get as much secretion of LH and FSH, and therefore you don't get as much secretion of the sex steroids. So this constant inhibition is going on, and it's limiting the increase in sex steroids and the increase in gonadotropin. And so your hypothalamus is relatively sensitive to feedback to testosterone if you're a male and estradiol as a female. Well, now look at this relationship as an adolescent and as an adult. Now, all of a sudden you need more of these sex steroids in order to feed back and get an inhibition of gonadotropin release. So what that means is that the feedback inhibition isn't as effective, and because it's not as effective, you end up with higher concentrations of these sex steroids. You need more sex steroid in order to keep the release of gonadotropin under control, which keeps the sex steroids under control. Okay, so you end up with a higher steady state level of the sex steroids, and it's thought to be because the feedback inhibition primarily upon the hypothalamus is less effective, and because it's less effective, you get more secretion of sex steroid before the secretion of gonadotropin and the secretion of the sex steroid has gotten back under control. Okay, so you have a steady state higher levels of sex steroid, and it's thought to believe, people believe that that's what takes place when you transition from a childhood to puberty and to adulthood. This is another way of showing that. This is sensitivity of the feedback mechanism on the y-axis, and this is different stages of maturity on the x-axis. And as you as you transition from infancy and childhood to puberty, at infancy and childhood, the sensitivity of that feedback is relatively high. And then it declines through puberty and as you enter adulthood. And that causes the increase in sex steroids, and that mediates the signs of maturity that you see and the development of sexual maturity and reproductive capacity. Okay? So there is a question of how this takes place, and I'll tell you right now up front, nobody knows the full story. Maybe it'll develop as you progress through your career, and maybe you'll find out more about it. But as of right now, there's a lot of theory and not a lot of facts surrounding this, okay? What we do know, at bare minimum, is that pre-puberty, the gonads are capable of producing adult levels of sex steroids. So it isn't that the testes and the ovaries aren't capable of producing enough testosterone and estrogen to mediate sexual maturity. And similarly, the pituitary is capable of producing adult levels of LH and FSH. So it isn't that as a child, the pituitary isn't mature enough to be able to do this. You can do it. Okay, so whatever it is that's going on, it's most likely thought to be upstream of these 2 points in the HPG axis. Okay, and what that leaves you is the hypothalamus, something to do with the hypothalamus and its sensitivity to these steroids. Okay, and so again, probably the hypothalamus is not ready to produce adult levels of GnRH. That won't allow the pituitary to produce adult levels of LH and FSH, which means that the gonads aren't allowed to produce adult levels of the sex hormones. Okay? So how does this work? This is one possible model for how it works. Again, this is all being sort of like worked out in a study. Has been for a long time, so I don't think it's going to be solved anytime soon. The theory for one model, at least, begins with leptin, which seems to be associated with this transition into adulthood. And leptin is actually secreted from adipose tissue. And so the more body mass you have, the more adipose tissue you have, the more growth you've achieved. And the more ready you are energetically to mediate reproduction, the process of reproduction. In other words, there's a lot of energy that's necessary for reproduction, particularly in the female, okay? And so the fact that you've attained a certain body mass and a certain amount of adipose tissue is a signal that you're ready to spend energy reproducing. At least that's the theory. So more leptin is released with increasing fat stores as maturity approaches. And leptin causes KISS neurons in the brain. It stimulates KISS neurons in the brain to increase secretion of KISS peptide, okay, in the hypothalamus, okay. So KISS1 neurons secrete KISS peptin, excuse me, KISS peptin acts upon the hypothalamus and stimulates the release of GnRH, okay? So what you have here is you have two competing things going on. You have negative feedback from the gonads in the form of secretion of estrogen and testosterone, and those are feeding back upon the hypothalamus and decreasing the amount of GnRH release. At the same time, you have KISS peptin being secreted, and that's stimulating GnRH. And the older you get, and the more body mass you have, the more KISS peptin you secrete, and the more stimulation of GnRH you release you get. So these two competing effects are like a seesaw. And what's happening is you get more KISS peptin, and that's causing this side to become heavier. And what it causes is an apparent decrease in the ability of estrogen and testosterone to limit GnRH release, okay? So there's an apparent decrease in sensitivity to the inhibition of testosterone and estradiol upon the hypothalamus. And that causes more testosterone and estradiol to be released, and you get more of the sex hormones. And that's thought to be part of how you initiate maturity. In other words, that's part of the reason why you get this sudden takeoff in plasma testosterone in the male and plasma estradiol in the female. This KISS peptin is becoming more and more effective in terms of stimulating the release of GnRH and making testosterone and estradiol less effective at reducing GnRH, okay? And that causes that apparent decrease in sensitivity that you see in a figure that I showed earlier, okay? Okay, let's talk very briefly about menopause. Again, we're going to focus on this as a clinical syndrome and life cycle. It is, menopause is the period where you get cessation of reproductive function in the female. It arises because basically the ovaries cease to function. Essentially what happens is the ovaries run out of eggs. And so you stop producing, when you run out of eggs, ova, in the ovaries, you stop producing estrogen, okay? And so when you stop producing estrogen, that causes a lot of effects that you get when you lack estrogen in the body, and these produce the typical signs that you see when you see menopause. I don't want you, at least for the physiology portion of this block, to concentrate a lot on this slide. Okay, these are just some of the things that you see when you lack estrogen in the body and when you enter menopause. Again, we'll worry more about what those effects are in the next block. Nevertheless, you should certainly be aware of some of these effects of lack of estrogen, and these you should be aware of for this course. First of all, do recognize the fact that there is estrogen in the male reproductive tract, and lack of estrogen will have an effect upon the reproductive system. It's needed for ductal fluid absorption, germ cell development, and differentiation. Okay. In the female, you should also, in addition to this effect in the male, these effects in the male, you should be aware of these effects of lack of estrogen in the female, or these effects of estrogen in the female. That's what it comes down to, estrogen function. In bone, you get a decrease in apoptosis of the osteoblasts. This causes more reabsorption of bone, and so you get osteoporosis, okay? In the vascular system, we didn't talk a lot about this in the vital fluids block, but estradiol is a vasodilator, and there is a certain amount of plaque protection that you get from estradiol. It's related to normal immunosuppression, which is associated with the development, of course, the immune system is associated with the development of plaques in the cardiovascular system, primarily. We're worried about that in the coronaries, they're not exclusively. There is an effect upon the central nervous system in terms of growth and neuroprotection and perfusion and stroke prevention, probably related to this effect of estradiol as a vasodilator. Okay, so you should be aware of those effects as well for this block. Okay. Thank you for your attention, and I will see you guys in the rooms.